Hello and welcome to the second edition of the YAS Partnerships for Life Global Initiative to Prevent Suicide bi-monthly webinar series. Es un gran placer dar la bienvenida a todos y a todas que nos acompañan el día de hoy de las Américas. The Partnership for Life is run by teams in 6 WHO global regions along the YAS Central Office. I am Elizabeth Seaward, a clinical psychologist, and one of America's lead for the International Association for Suicide Prevention's Partnership for Life initiative. I shall host today's webinar on behalf of the regional team. As of early 2026, the previous regional lead, Mark Senior, stepped up to the role of global lead. The regional team is now co-led by sub-regional leads Elizabeth Seaward, myself, in Central America, Mexico, and the Caribbean, Karen Scavacini in the South, and Richard McKeon in the North, with support from Emily Chan and Daniel Sanchez Morales in Canada. The webinar will run for approximately 90 minutes, during which there shall be 3 presentations on developments and ambitions in the 3 Americas regions. Attendees can ask questions during the webinar by pressing the Q&A button at the top of your screen and entering your text. We encourage everyone to share their thoughts and will aim to take as many questions as possible in the time that we have. Unfortunately, there will not be simultaneous translation available today, but the webinar will be recorded and uploaded to the YAS website, permitting further study. Without further ado, I shall begin today's presentations by presenting Partnerships for Life in Central America, Mexico, and the Caribbean. Thank you very much. As I said before, I am a clinical psychologist who has worked in private practice for over 25 years. I am the president of the first association dedicated to suicide prevention in Costa Rica, ACEPS. I have also worked as an external psychologist for the refugee department for ACNUR in Costa Rica. And I was one of the team members who created the first program for suicide prevention that was implemented in a community, in a community-based strategy in the Municipalidad de Curridabat, Costa Rica. Please change the slide, Simon. Thank you. I would like to start today by reminding all of us that mental health, as we can see in this quote that comes from the World Mental Health Today latest data report from the World Health Organization, mental health remains one of the most neglected areas of public health and health services delivery. It's really surprising that still in 2025, 2026, we're still struggling to get mental health on the table and listened to and part of public policy and everyday life in the services that our populations and our citizens look for. And I think it's important for all of us who are working on this subject to remember that we still need to advocate for our governments and our countries to take mental health into account. Sometimes when one has worked on these things for a long time, we forget that there are still many areas in our countries that are not aware of it or don't believe that mental health is important. Could you change the slide, please, Simon? Thank you. 1 billion people worldwide live with a mental disorder. That means that it is more prevalent than many of the diseases and the illnesses that have been taken into account in public policy and public funding. And so these 1 billion people still need us to be advocating for their needs and for their well-being. On top of that, $1 trillion in annual global productivity worldwide is lost due to mental health disorders and mental health issues. So really, it should be a priority of our governments to take mental health into account. But I think often, many times, the people that are making the decisions don't realize those numbers. And so part of the work that we do in suicide prevention is to give these numbers back to the people who make the decisions so they can understand why we are constantly advocating and raising our hands to take mental illness and suicide prevention as one of the main aspects of our government policy. Simone, thank you. 2% of healthcare budgets go towards mental health worldwide. But in the region of Central America, Mexico, and the Caribbean, 2% goes only to healthcare, not to mental health care. So that means that 2% is then sliced into a very small piece that is then provided for professionals and community-based programs to work on suicide prevention in their communities. Simone? Now, knowing that information, that such a small amount of money is directed to mental health programs and to suicide prevention, it's incredible that in this region, there's one mental health worker per 1,000 people. That is an amazing statistic when we look at it in its rawness. That means that most people will not be attended to adequately. So in the region that I work in, and in low income regions, 9% of people with depression receive no adequate treatment. Only 9%. That is a very small amount of people who are receiving the mental health care that they need. So that means that we have to be creative in Central America, Mexico, and the Caribbean. That means that we have to think a little bit out of the box. In what way can we help the people that are coming to us who are suffering with depression or with anxiety or other mental disorders? Simone? The realities of my region are go from one extreme to the next. We have some countries like Costa Rica that has mental health laws that has included now for many years suicide prevention as one of the important points that need to be funded and need to be worked on and taken into account. But then we go to another extreme where we still have countries that are trying to decriminalize suicide. And that even though maybe people are not taken to jail for suicidal thoughts or for suicide attempts, it is still considered within the law a criminal act. So that means as a region and as a community, as a region, we have a lot of challenges that we have to look to and have to deal with from many different perspectives. And that's the idea of being able to work as a community where we can help each other within the region to move along the countries that are still starting from the basic baseline, and other countries who were a lot more advanced in our suicide prevention programs, but are still facing a lot of challenges. In many countries, I'm sorry, Simone, could you go back? Sorry, thank you. In many countries, because the healthcare laws do not include mental health and do not include suicide prevention, the strategies that exist are very fragmented. And very often in this region of the world, what is happening is that suicide prevention is not being dealt with from the top. It is being dealt with from the bottom. And that means that it's individual people and it's people within the community who are doing their best to create suicide prevention programs, activities, and strategies. But that means we're all working separately. And that means we're not strengthening our programs because each one is doing something different and not helping each other. In that sense, the way that we help the region and the way that we grow as a region in suicide prevention needs to maybe be looked at differently from other countries in the world. Very often we start with trying to get public policy in, and public policy is extremely important because we will not be funded, we will not be backed up. Our public healthcare systems will not have the tools that it needs if we do not have public policy in place. But the reality is that we have people every day who are struggling with their mental health and who are struggling with suicide ideation, and we need to help those people as well. So we need to think about those individual professionals and those nonprofit organizations that are doing the work out there on the front lines when we think about how we approach suicide prevention in the region of Central America, Mexico, and the Caribbean. Simon? So what are our challenges? There are many, but if we look at all of them at once, then we become completely overwhelmed. And the past 25 years that I've been working in office with government, in communities on suicide prevention, I have learned that you choose a few things and you work with those and you go one step at a time. So what is one of the first things that we need to do? We need to continue to creating awareness and educating. And once again, in this region, from my experience and from talking to other professionals in the community and in other countries, maybe sometimes we need to start with the people who are actually working within the communities and giving them the awareness and the education that they need. That then permits the actual community to start speaking up and telling their politicians and their government and their different institutions what they need and how they need those funds to be directed to helping them. Because very often the people on the top have never even spoken with somebody who has suicide ideation or has had a suicide attempt or has lost somebody to suicide. And so I think if we can educate the people on the bottom, that helps us to educate the people on the top. And within the region, we're still struggling with the stigma of mental health, and even more stigma when we talk about suicide. And so we need to continue giving the community information so they understand the myths, the challenges, the false ideas that exist about this topic, and how people suffer and why they suffer in the way that they do. We also need to give training to a wide range of professionals. We cannot just train psychologists and psychiatrists. That would be wonderful if we had enough of them in order to do that work, but we need to train school teachers, we need to train nurses, we need to train social workers, we need to train a huge wide range of professionals so that all together we can do this work. Because if we just expect the professionals in the healthcare system or in the hospitals to help the people who are suffering with suicide ideation, then we will not be able to help the community. So we need to open up our training resources to more to different areas and different professions. And we also need to provide these community programs with more science-based tools and knowledge. Often it's the Little League football team, or it's the girls who are the cheerleaders group, who are actually providing mental health tools, but they do not have the training or the information or the clarity what their job is in the community of suicide prevention. So it's important that we can also get that information to them. Simone? Thank you. So what opportunities we have? I think we have many, and especially with Partnerships for Life in the Americas, it's an amazing opportunity to create a network and a community throughout the continent where we can share our ideas, where we can share our experiences, where we can learn from each other, and where we can start feeling like there's somebody beside us that's helping us and that's listening to us, because it's very lonely work that we do, working in communities, working in our offices, and working with very little funds and very little backing from our government institutions. So I think this is a wonderful opportunity that we can start communicating and getting to know each other. I think it's also an opportunity maybe to start creating a virtual library. And with that virtual library, we can all share the tools and the experiences that we have created in our communities. And that way we can get more information out to more people. And, we can take advantage of the technology that we have in the modern world. And we can open up this network, not just talking, not just proposing, but also giving people more concrete things that they can use. And another great and amazing opportunity we have is the Pan American Conference that's coming up in November. I'm very proud and very honored that it will be done in Costa Rica. It's a very beautiful country. It's in the middle. So I'm really hoping that a lot of people can come and that we can share. And it's an opportunity that we can share in Spanish, in Portuguese, and in English, everything that we've been doing together, and that we can grow and create new possibilities throughout the region that are more geared to our cultural needs, to our social needs, and how we are able to work with suicide prevention. Simon? So what is the goal of the region? Not just the region that I'm leading, but I think also of the other two regions, is to create an America's community where we can work together, where we can navigate the challenges, and we can continue on this endeavor of advancing suicide prevention for the future, for today. With the tools and with the opportunities that we have a lot of challenges in this part of the world, as other parts of the world do as well. But I think these challenges shall be our strengths. We should not look at them as our impossibilities, but I think it's a way to be creative and to work together and to grow. Thank you. Thank you, Simone. So now we shall continue with our second speaker, who is Richard McKeon, Dr. Richard McKeon. Richard has been engaged in international suicide prevention efforts since 2007 through RIASP and the Global Leadership Exchange. He has contributed to global initiatives, including the development of the World Health Organization World Suicide Report and the U.S. National Strategy for Suicide Prevention in its 2012 and 2024 initiatives. He has been involved in Partnerships for Life efforts, supporting the development of national suicide and prevention strategies worldwide. And he shall present today Partnerships for Life in the United States and Canada, which will give an overview of the current status of efforts to develop and implement national strategies for suicide prevention. And it will also explore the opportunities for strengthening collaboration in the Americas and advancing evidence-based strategies. Richard, it's all yours.
Thank you so much, Elizabeth. And my apologies that I am not using slides, which means you'll be looking at my face much more than you would if I was using slides. So apologies for that. I am very grateful to be discussing Partnerships for Life in the Americas, and particularly a status within the United States and Canada. I think the wonderful part of having an initiative like Partnerships for Life, focusing on the Americas, is that we can all learn from each other. Whether you're a high income country or a low income country, that mutual learning is so important and so vital. Of course, high income countries have advantages that low income countries do not. And I will start by talking about the United States. I'll probably talk about the United States a little bit more than about Canada, because I know more about the United States than Canada. But I will point out some really important things going on in Canada as well. So in the United States, we are a nation, and there are a handful around the world, that we're actually on our third iteration of a national strategy. There are other countries that are similar, Ireland, Australia, and others that have had more than one national strategy. So the issue for us is not how to get a national strategy, it's how to make sure that that national strategy is implemented. Now, in the United States, our first national strategy was released in 2001. And actually, that strategy was, again, and all three of our strategies have been very designed to be comprehensive approaches to suicide prevention. That strategy also contained an idea for how to monitor implementation of the national strategy. One of the objectives in that strategy was the start of what would be called a National Action Alliance for Suicide Prevention, a public-private partnership to promote implementation of the national strategy. We did launch the National Action Alliance for Suicide Prevention, but not until 2010, so 9 years later. So there was a significant gap. But once the National Action Alliance was started, the National Action Alliance worked with the U.S. Office of the Surgeon General and multiple federal agencies and private nonprofit organizations to revise the national strategy. And that second national strategy was released in 2012, and I was honored to be part of the group that worked together on that revision. And so, we were very glad to get that out and now to have it with a National Action Alliance that could help with the monitoring. The national strategy was always designed to be a plan for 10 years. So we revised the national strategy yet again in 2024. So in 2024, the third iteration of the U.S. national strategy was released. And so our focus now that we have a revised, up-to-date national strategy, our focus now is how to be able to track more closely on whether the national strategy is being implemented, because a national strategy is very important to guide efforts, but it needs to be able to drive forward actual suicide prevention activities that one would hope, because the national strategies are based on evidence-based approaches. The hope would be if we increase the activities should lead to a reduction in suicide mortality and morbidity. But if the activities that are called for in a strategy aren't actually happening, then one would not expect that there would be a reduction in suicide deaths or suicide attempts. So the current focus now within the United States is on looking at how we can best monitor that. The National Action Alliance has a initiative called Hope Counts that is working to identify what some of the key indicators would be that we are making progress in implementing the objectives in the national strategy. So that is one important part of what is happening in the United States. I'm also going to mention another major initiative that is incorporated in the U.S. national strategy. Has to do with suicide and mental health crisis hotlines. And of course, such hotlines exist all over the world in high-income countries and low-income countries. And they are of unique importance in being able to provide rapid access to help, to support, to counseling, etc. In the United States, we have had a national hotline system since 2001, the same year that the national strategy was released. That structure has been called the National Suicide Prevention Lifeline, which was a network of many crisis hotlines all across the country in every state in the United States. It also allowed us to do a lot of evaluation work to understand what was working on the hotlines, what needed improvement. And so there has been really a long trajectory, over 25 years now, of the development of our hotline system. And that became the structure or the foundation for the most recent, extremely important iteration of the national strategy, of the national hotline system. So for years since 2005, the number that we were using was a 10-digit 800 number, 1-800-273-TALK, 1-800-273-8255. But one of the things that then occurred in the United States was there began to be efforts to look at, can we improve that by having a three-digit number that could be remembered more easily during a suicidal crisis and might allow us to reach more people. And there were two pieces of federal legislation. There were the National Suicide Hotline Improvement Act called on SAMHSA and the VA to do reports, to send them to the U.S. Federal Communications Commission. And the FCC also had to do their own reports about the feasibility of having a three-digit number. The FCC then recommended to Congress the establishment of a number, and that number be 988. And that was then followed by the passage of congressional legislation that established 988 as the new national number, with a mandate to have 988 be available on every landline, every cell phone, every voice over internet device in the United States. And that this was supported through an order by our Federal Communications Commission with a deadline of July 2022. And so by 2022, all of those phones, cell phones, landlines, voice over internet devices enabled 988. Additionally, at the same time, the FCC did an order that 988 be made available by text, particularly important for accessing for young people. And the 988 in the United States has really worked extremely well in terms of what we had hoped for. that each year we respond to millions of contacts. The financial support for the local crisis centers has increased significantly over over that time period, and the number of callers continues to go up. We were also particularly pleased yesterday. The Journal of the American Medical Association published a research note that found that the launch of the 988, and the official name now is the 988 Suicide and Crisis Lifeline, was associated with significant reductions in suicide mortality among adolescents and young adults nationally, and that the observed reductions were larger in the states with the highest uptake of 988 Lifeline services. This was, of course, exactly what we were hoping. We knew that many more people were accessing the service, but it is wonderful that we now have some evidence that it is doing what we had hoped it would do, which was to intervene successfully in suicidal and other mental health crises. And we think likely the availability of chat and text services, which are disproportionately utilized by youth and young adults, likely plays an important role in this. So that is, a brief overview of what is happening in the United States. 988 is not the only part of suicide prevention in the United States. There are multiple federal agencies engaged: SAMHSA, CDC, NIMH, the Veterans Administration, Department of Defense, who all have roles to play in suicide prevention, as well as many different nonprofit organizations, such as the American Foundation for Suicide Prevention, the National Association for Mental Health Program Directors, which is our state mental health commissioners, the National Council for Mental Health Care, and others, who have all come together to work on improving crisis services, but also promoting more comprehensive suicide prevention. The United States has a youth suicide prevention grant program called the Garrett Lee Smith Grant Program, and we have published in the literature studies that have shown that implementation of grant-funded activities is directly associated with reductions in suicide for that program as well. So we are encouraged. Particularly important because in the United States over the last 25 years, there has been an upward trend that we are hopeful has now been modified because we have seen modest reductions, but it is still far too high. Approximately over the last several years, 49,000 Americans died by suicide. So much more is still needed to reduce that number. Let me also talk a bit about suicide prevention in Canada. Now, Mark Signor would be much more qualified to talk about this than me, but I'm going to give it a go. The Canada does not have a national strategy, but it does have some national efforts. So Mark and others have led efforts to try to encourage the national Canadian government to adopt a national strategy. But there also is important work going on in the provincial level, just as there is on the state level in the United States. In fact, the Quebec suicide prevention program showed excellent results, going back over a number of years. So these, the provincial level and local level is so important. And those efforts, of course, can proceed without a national strategy, even though we think having a national strategy is helpful. Now, 1 year after the United States implemented 988, Canada also implemented 988. So we have ongoing communications and consultations between the US 988 system and the Canadian 988 system. So we can learn from each other since we are in very similar paths moving forward. And the Public Health Agency of Canada has historically been very involved in suicide prevention in Canada and has been involved in what's called the Global Leadership Exchange. It was called the International Initiative for Mental Health Leadership, which is an organization that has had some focus on suicide prevention going back well over a decade. And I don't remember the exact year. 1 year it was hosted in Vancouver, but it will be hosted in Ottawa this coming June, with a suicide prevention component taking place in Toronto. So the internet, if you are interested in that, we can certainly get you more information. The nations who participate in the Global Leadership Exchange has actually been increasing. Historically, it was the US, Canada, England, Ireland, Scotland, Australia, New Zealand. More recently, Sweden and the Netherlands have joined. So leadership has been expanding. The benefit of it is that it engages the mental health leadership in each country. And so, as Elizabeth, you have to work from the bottom up, but you want to be able to engage the leadership in these efforts. So I am going to stop there, and we can move on in our agenda.
Thank you very much, Richard. Thank you. I think the US and Canada has so much rich and important experience that will help regions like my region and like Karen's region, to do some of the work without having to start learning how to make the white bread. You guys already made the white bread. Now we can take it from there. So thank you very much for your presentation. We shall continue now with Karen Scavacini. She is a master's in public health. She is a psychologist. She is a co-founder and head of, and forgive me, Karen, because my Portuguese is not particularly good, but the Instituto Vitalere de Prevención y Posvención, I don't know how to say it in Portuguese, de Suicidio in Brazil. But she will teach me, I will learn. Her work focuses on suicide prevention, postvention, and mental health promotion through training programs, public campaigns, and support initiatives for professionals and communities. She has developed national initiatives, including the Mental Health Map, which has reached over 2.5 million people across Brazil, and programs for schools, universities, companies, and public services. Her presentation today is Partnership for Life in South America, Objective Challenges, and the Path Forward. Take it away, Karen.
Thank you very much, Elizabeth. And you spoke perfectly. Vitalere Institute, it's perfect. And my surname also. So thank you very much for that. Let me share my slides with you. Just a second. Okay. I imagine that you can already see it. So good morning, good afternoon, good evening, wherever are you joining from. Thank you to YASP for this space and to everyone working in suicide prevention across Americas. I'm honored to speak alongside my colleagues, Dr. Elizabeth and Dr. Richard. And I would like to share a South American perspective on partnerships for life, focusing on the objectives, regional challenges, and the path forward. I'm Karen Scavacini, and as Elizabeth just mentioned, and I'm lead the Partnership for Life in South America. And I'm also a IASP representative for Brazil. I'm founder of the Instituto Vitalere in São Paulo. I'm also one of the founder associates for the ABEPS, Brazilian Association for Studies and Suicide Prevention, and ABRACES, Brazilian Association for Suicide Survivors, and co-founder of Vertentes and mental health ecosystem in Brazil. In the next 15 minutes, I want to do three things. Map what we are facing as a subregion, name what is missing in my point of view, and share how the South America is trying to respond. I also invite everyone that is watching to write at the comments here and the chat from Teams. Where are you from? And if you work or not in suicide prevention field. And also feel free to write your questions, any questions that you have. So I hope that I can see where are you from. Okay, let me start with a global picture. In 2021, the World Health Organization estimated 727,000 deaths by suicide worldwide, and suicide was the third leading cause of death among people aged 15 to 29. And 70% of suicides occur in low and middle income countries. In the region of Americas, PAHO reports approximately 100,000 deaths by suicide in 2021, with an age standardized rate of 9.2 per 100,000. One numbers matters more than any other of this slide. Between 2000 and 2021, the suicide rate in Americas rose by 17%. And we are the only WHO region that the rate are increasing. The single fact that frames everything that I'm going to say next. So South America is a heterogeneous subregion, not a single policy environment, with a very different health systems, very different data capacity, and very different cultural and linguistic realities. Territorial inequalities, remoteness, and border dynamics shape how services are organized. We also see a high concentration of services, where national averages often hide sharp subnational disparities. Our strategies must account for cultural diversity, including linguistic and indigenous needs, and address the data asymmetry in surveillance maturity across the countries. The rates illustrate this clearly. Guyana and Suriname are among the highest rate countries globally. Uruguay has been a consistent outlier in the Southern Cone, above 20 per 100,000 in the recent years. And Brazil as a whole reports around 7 per 100,000 in 2021. But the national average hides state-level rates, like Rio Grande do Sul with a 12.4 and Santa Catarina with a 10.6, according to DataSUS. This has a directly operational consequence. A regional strategy must be comparable across the countries, but they will never and they cannot be uniform. Anything we build has to allow for local adaptation from day one. And then when I talk to colleagues across the region, the pattern that I heard is very consistent. The problem is not just the absence of initiatives. Almost every country has something, even a protocol, a campaign, a training program, a helpline. The problem is that these initiatives are dispersed, weakly connected, and hard to compare. Elizabeth told a little bit about it, so we can see that this is not just a South American problem. Practical knowledge is often trapped inside institutions or local networks. Countries face similar needs without a structured mechanisms for exchange or adaptation. And this fragmentation has a cost. It slows implementation. It makes every country solve the same problem from scratch. And it makes it harder to recognize what is actually working. So Elizabeth also told a little bit about these questions. The first systemic challenge is data. PAHO has identified strengthening surveillance and monitoring as a strategic regional priority. But the issue is not only availability, it is usability. Across our subregion, we see delays in processing, weak disaggregation by age, sex, territory, and ethnicity, uneven public access, and limited usefulness of data for local planning. And regional learning requires better use of data, and not only just more data. The second challenge is funding and access. According to PAHO Mental Health Atlas, only 2.1% of health budgets in the region of the Americas are allocated to mental health, and 42% of that spending still goes to psychiatry hospitals rather than community-based care. The consequence is the treatment gap. PAHO reports that more than 77.9% of people with mental health disorders in Latin America and Caribbean do not receive care. It's 3 out of every 4 people. It's too much. Suicide prevention cannot be separated from this broader picture, where community mental health is weak, suicide prevention is weak. And the third challenge is that the burden is not evenly distributed. Certain populations carry a disproportionate risk and are consistently underrepresented in national plans. Indigenous communities, especially in the Amazon basin and Indian countries, face rates that are often multiples of the national average, linked to historical trauma, territorial loss, and cultural rupture. Incarcerated populations are an emerging concern. According to the World Prison Brief 2024 report, the prison population in South America has grown by 224% since the year 2000, more than tripling. This population is structurally exposed to suicide risk and almost entirely invisible in national prevention strategies. Rural and border communities, LGBTQIA+ population, and older men and people bereaved by suicide are often groups where existing actions are teams. And this is the context in which Partnership for Life operates in South America. For the ones that not so familiar with Partnership for Life, is a global collaborative model from YASP to support countries in building and strengthening national prevention strategies. And it's grounded in the WHO Life at Light Implementation Guide, which proposed 4 evidence-based interventions: limiting access to means, responsible media reporting, and social emotion skills for adolescents, and early identification and follow-up of people at risk. What Partnership for Life adds at the sub-regional level is structured coordination, a mechanism that can connect everyone that is interested and reduces the fragmentation I described. To address these issues, we have launched the South America Coordination inside Partnership for Life. This is a strategic initiative to identify, organize, and reuse existing tools across the continent. Our process flow moves from structured data collection and validation into analysis and implementation. We aim to categorize tools to reduce fragmentation and ensure all shared content meets YASP standards. So let me show you specifically what we are doing in South America this year. Phase 1 runs from February to June, foundation and mapping. We are defining a common region framework to capture what exists, like projects, protocols, training material, campaigns. We are collecting structure inputs from partners in each country, and we are identifying recurrent gaps and underrepresented represented populations. Sorry for that. Phase 2 runs from July to November, consolidation and application. We are refining a shared repository based on partner feedback. Almost like the same that Elizabeth told you just before. So we are going to do everything together. And we are supporting peer exchange between countries with similar needs. For example, prison protocols or youth-specific campaigns. So that what works in one country can be adapted in another without they need to starting everything over. The year ends with a regional synthesis feeding into the American level reporting. So the cornerstone of this project is this repository. I would love this to be physical, but I'm sorry, this is in a IA made. It will centralize, it will be online, of course. It will centralize protocols, campaigns, and training models. And it's designed to be a multilingual, supporting Spanish, Portuguese, and English, to ensure that it's accessible and scalable while reducing the operational burden on individual nations. Of course, that we cannot translate all materials to every language, but it will be separated. For example, those are some of the materials we do have from Vita Alegre. They are in Portuguese, but they will be available for everyone that get interested or needed. And there are so many nice materials in South America, and I will count on you to help us to build this repository. And we have defined the success criteria for this year. Engagement with partners from at least 5 South America countries, documentation of 15 to 20 initiatives, one functional shared repository in active use, and at least one concrete example of cross-country reuse. A regional synthesis that contributes to the annual Partnership for Life report. And the test is simple. By November, the region should know more about itself than it did in January. Useful materials should stop being isolated, and the work should should help people that need. Before I close, I want to invite you to contribute directly. On the screen, you will see 3 QR codes, and we are going to put the bit.ly links at the chat. The English version, the Spanish version, and the Portuguese version of the regional mapping questionnaire. It takes 10 to 15 minutes to complete it, and it maps initiatives, gaps, and opportunities for collaboration in your country. The YASP national representatives will receive one specific for them by email, so you don't need to answer this one. The responses will feed directly into the repository we are building and into the 2027 strategic plan. If you cannot complete it now, of course, because we are here now together, please keep the link. and share with your colleagues. Every response strengthens what we can offer back to the region. And because I made for South America, and not all the countries from the Americas are listed, but if you are from another country outside South America and want to fill the questionnaire, please feel free to do it and put the name of your country. Do not please, then I can share with Elizabeth and Richard after. And suggestions for the project are more and more than welcome anytime. And then I invite you for the forum, YASP Pan American Forum that we are going to have in Costa Rica this year. And I really hope that I can meet most of you there in person this year. This was the references that I use, and I will leave you with one idea. The gap in suicide prevention in South America is not primarily a gap of knowledge, it's a gap of coordination, visibility, and reuse. If we get the coordination right, we can benefit a lot of people. And thank you very much. I will be glad to take questions. Please feel free to reach me out in my email, and I really hope to see you all in person in Costa Rica in November. Thank you very much.
Thank you very much, Karen, for your amazing presentation, for your passion, for your organization. I think you can see how we have a continent with probably three very distinct realities, but with very common goals. And I think the initiative of YASP and the initial work really of Mark, Senor, and Daniel makes this possible. And now the possibility that we've divided this up in the three sub-regions, I think we can do truly, truly amazing work together. So I thank Karen and I thank Richard very much for their presentations, for their overviews, and that we can start to get an idea of where each region has its challenges, but where as a community together, we can start facing those challenges. So I would like to open up now for the questions, for the moments for the questions. You can ask questions to any one of us. I believe Simone is the one who's going to read them, unless they want me to read them, however they wish to do it. But I invite anybody who's connected to please give us your ideas or your observations or your questions.
There's a question here at the chat for Richard. What is the relationship between gun control and suicide rates in states where there are stricter gun control laws?
Yeah, so there are a number of things that I would mention there. Obviously, reducing access to firearms has been a part of the U.S. national strategy. The focus really has been in recent years on trying to promote safe storage, trying to work cooperatively with places like gun shops, shooting ranges, etc. In the United States, rural states have higher rates of suicide than or urban and suburban states. And in fact, in every state, rural areas have higher rates of suicide than urban and suburban areas. And clearly one factor in that does have to do with access to firearms. There are some states that have initiated called red flag laws to allow, when there's evidence of dangerousness for the family or others, to step in and petition for firearms to be removed. But clearly in the United States, the right to bear arms is zealously guarded. So one of the things that the suicide prevention field in the United States has really, done is to really try to figure out how to work cooperatively with gun owners, and other organizations, to promote awareness of suicide prevention resources and to promote safe storage. So, for example, in the U.S., a number of states and a number of federal grants have supported things called the gun shop projects, which are really working cooperatively with gun shop owners for them to have information about suicide prevention and to promote safe storage. Additionally, in the U.S., the Veterans Administration has developed communication campaigns also aimed at safe storage to reduce the access to lethal means, because we know that sometimes the intensity of suicidal urges might only last for a short period of time, perhaps only for minutes or an hour. So not having firearms or other highly lethal means immediately accessible during such times is particularly important. So that would be the way that I would answer, that question. And so reducing access to lethal means has been a part of each of the three U.S. national strategies that have been released.
Thank you, Richard. Karen, you have two questions. Would you like to take the first one? If you could talk about the Bolsa Familia program and suicide rates in Brazil.
Okay, so yeah, I do not have all the numbers with me right now, but we had this amazing study from Diane connecting the Bolsa Familia with suicide rates. So Bolsa Familia, it's one program from our government that they give some money from people in some type of with a type of income, and it can help them to, buy food or wherever they need. And the children need to go to school and they need to be vaccinated to get this Bolsa Familia. And she had the brilliant idea to connect the Bolsa Familia and suicide rates. And what she discovered is that, of course, there was a decrease of the rates during the Bolsa Familia and in some regions. So she could really connect how financial straight can be very difficult for the families and for the people. And when you give them some kind of support for them to have at least decent life or to have something to eat, this can really be connected to the decrease of the rates in suicide. And I can send you, Murad, after the link for the Diane study, but I can tell you that it was a really, really nice one. And she could prove that the financial help, it's connected with the suicide rates.
Karen, you have another question from Mark about Uruguay as a substantial outlier.
Okay. Yeah. So, Mark, I do not have now all the factors that we can compare, that we can, why can, sorry. Okay, again, Mark, I do not have all the driving factors from Uruguay right now, but I know that they have a lot of suicides in the security forces, and they made some projects about it. And I cannot tell you other factors really like from Uruguay right now because I do not want to give you wrong answer. So I can, I don't know, Elizabeth, if you know it, but I can, no. Yeah, I can research that and I can send you after. Sorry for that, Mark.
Well, no, I think that's part of what we're starting to do. No, today's initiative. In a moment, I will give the question to Richard. In this initiative, where we have divided up the groups and the regions, will permit us to study much more in depth what is happening in the three regions. But we've just started, as Karen said. We just began in January, so we're getting on our feet. We're learning the ropes, but we are definitely geared to start learning more about each one of the countries that are in our regions. Richard, there's a question for you. It says, what group is driving the uptick in suicide numbers in the US? Sex, age, social status wise?
Yes, that's a great question. And again, so the trend has been up over the last 25 to 26 years, but appears to have moderated over the last couple of years. And so there have been increases among men, among women, but the ratio of men to women who die by suicide in the United States remains about 4 to 1. So it's overwhelmingly male. Historically, in the United States, um, uh, older Americans had the highest suicide rate. Younger youth had the lowest suicide rate, and then in midlife, it was about in the middle. That changed during this period with an increase, particularly among midlife. Um, that's led to more efforts because it's clear that youth suicide prevention efforts have been going on for a much longer period of time in the United States. And so there was a recognition that more needed to be done for adult suicide prevention. And just like school suicide prevention is an important part for youth because that's where you find most kids, that engaging the workplace in suicide prevention really is an important piece for adult suicide prevention. Now, among youth, it is, there's an interesting trend. And as I mentioned, we were very heartened on the decrease in youth suicide prevention from what we would have expected um, among youth and young adults, which we think 988 and chat and text availability may have played a role in. But part of what happened was that youth suicide, which had been on a trajectory, increased even more during COVID, right? Which was somewhat counterintuitive because in general, suicide did not increase, during COVID. And I think one of the things that we missed was that while the physical impact on youth of COVID um, was much less than among older adults who are much more vulnerable, it was really reversed in terms of the psychological impact with schools closing, etc. Youth suicide went up during that period of time. But now it has started to go down, which we are heartened by, and trying to build on the efforts like 988, like our Garrett Lee Smith Youth Suicide Prevention grants, and with promoting the new U.S. national strategy to try to work with all groups, with all Americans, to try to reduce that. Because even though there are some hopeful signs, 49,000 Americans dying each year is just far, far too much. So there's so much work. While we're glad for what we've been able to achieve, there's so much more that needs to be able to be done. And the other thing I would mention is that it's really important when thinking about suicide rates to be aware of the numbers as well as the rates, right? Because the suicide rate in the United States is too high. And so if one group or another, like college students, for example, have lower than the average US suicide rate. But that doesn't mean that we shouldn't be focusing on suicide prevention among college students, because we don't want an unacceptably high baseline to be the standard. Whether a particular group is at as higher than the national average, lower than the national average, we want to promote suicide prevention for all Americans.
Thank you, Richard. There's another question for any one of us. In relation to youth suicide prevention, how do you engage the family, given that their socialization is primarily curated in that space? How does culture affect this approach? Karen, Richard, would either of you like to speak about that?
Oh, I can start, because family is often one of the most powerful protective factor that we can see, and it's not, of course, an automatic protective space for every young person. So first of all, we cannot like romanticize the family, and we need to access how the family works. Obviously, I'm not blaming family for anything, but we need to understand how the family is working. And it's really difficult sometimes to engage family, especially if they do not want to do it. So I think real communication and put the family as part of the prevention. It's something that we need always to consider the connectedness, and if there have other career adults that can be associated, it also helps. At least here in South America family, we have sometimes it's really difficult, the relationships, but it's a really central part of the culture. The points that what we can see, for example, for LGBTQ plus young, sometimes the family, they are the source of violence or prejudice, and then it can turn to risk factor.
I would add to that, in private practice, at least in my area, I've noticed in my region that many times families feel that they are incorrectly given the responsibility for everything that's happening to the person in the family who is struggling. So I think it's important as professionals that when we work with families, we try to help them to understand that guilt doesn't work and nobody is guilty for what's going on. There are responsibilities and there are dynamics that happen that make it difficult. And because there's also a lot of families who the parents are also struggling with mental illness. I have a lot of young people or people who come in who their partners are also struggling with depression or with anxiety or with severe mental illness. And I think sometimes if we don't work and open up with the whole family, that we listen to all of the suffering in the family, then families don't come. And families don't open up. They kind of push us out. So I think it's a challenge, but I think a challenge is very much for us who are working in directly with the people, that we can help them to understand that talking about the things that are happening in their families is not looking for blame. It's just trying to understand. We have some more questions. This is wonderful. Keep your questions coming, please. So I will go in order. There is another question for Richard. It says suicide rates in Black males in the US are much less than white males. What, in your opinion, are some of the protective factors in Black males, given they are a significantly discriminated group? Very interesting question.
Yeah, that is a great question. Let me mention a couple of things. And actually, the group that group that has one of the lowest rates of any group of suicide in the United States is Black women. And I think for Black women and Black men, I think the role of the church is really important as part of a tight-knit community structure. We know connectedness is hugely important. But it's also the case that there have been some concerning trends over time, particularly among Black male youth. And in fact, some researchers from Ohio State began looking at this because when you looked at youth suicide in the United States, American Indians and Alaska Natives had the highest rate, followed by Caucasians, and then followed by Black and other. But that changed over a period of time, and almost unnoticed at first until this research from Ohio State identified and looked at it that that Black youth had a higher rate of suicide than Caucasian youth. And that change had switched, which leads to important questions for prevention, right? Which was what was having this increased negative impact on Black youth, right? That was leading to this increase. So it's part of why it's important to be able to look not just at the absolute rate, but also the numbers and the trends, right? And so the concerning trend was that it was increasing. And that it meant that in suicide prevention, we needed to, pay additional attention to that. So there have been, for example, there have been policy academies that have been sponsored by the federal government on Black youth suicide, trying to bring in experts and, of course, and understanding what we can do. And of course, a suicide prevention program can do some things, but not all things. And there are a lot of just as an example, general economic factors, or discrimination are not things that, in terms of having a macro impact, most suicide prevention programs per se cannot, and it may require larger cultural changes. But, part of suicide surveillance is looking at these trends and then trying to ask the key questions. Whether the trend is worrisome, such as the increase in Black youth suicide, or the more encouraging trend that was reported in the Journal of the American Medical Association yesterday about the decrease that looks to be associated with 988 and the increased utilization of chat and text services by youth in that. That, by the way, did not have any information regarding differences according to different groups, other than that the focus was on age, and that was what was shown. I think you're on mute, Elizabeth.
Thank you, Richard. We have a question from Katya. It says, I am based in the UK and work voluntarily with immigrants from different countries, excuse me, of South America. My cultural knowledge is severely lacking. Are there any resources you could point me to as a starting point for learning? I think that's for Karen, South America.
So, Katya, thank you very much for your question. So I think the most important part is that not just a single South America culture to learn. Even in Brazil, there are very different structures in family, religion, race, class, migration, histories, and how the stress is understood and how the stress is expressed. So trying to understand each part of South America the person is, and maybe to do like a cultural formation interview to understand how long the person is abroad and if it's the first, the second, or the third line of the migration, because we know that this influences the suicide rates. And When I read your question, I was thinking about soap operas, but maybe you can watch some soap operas from Brazil, from South America, and try to understand a little bit more. But this is definitely not a scientific point of view, okay, Katia? And actually try to understand from the person how they experience this migration. And I know that UNICEF also have a lot of materials that you can have a look about migration and how they can connect and community engagement. And I think it's important also to know if the person feel that belong to any community in UK, because there are a lot of Brazilian, Mexican, no, Mexican is not South America, or Uruguayan, Argentinian communities across the UK.
Yes, Karen, I was also thinking watch movies, no?
Oh,
From
yes.
this area as well as soap operas, or read novels. It's amazing. There are
Yes.
so many novels now that are translated into different languages. So also reading novels that are written by people from different cultures is a wonderful way. Mark, we have an answer for you about Uruguay from Carlos Felipe. It says Uruguay has a long time of stability with stable politics, less social inequality in the population, stable health and education services. I think these social determinants are very important in the scope. I agree with you. I think that helps in many countries. Okay, do we have any more questions? Okay. Here, we have one more question, and then I think we will be wrapping up. The absent father, regardless of ethnicity, is a global concern for the developing child. Do you find any correlation to an increase in suicidal ideation and attempts with the absent father? Richard, Karen, would either one of you like to speak about that?
I mean, I think that that is a great question. And I agree entirely that the absent father is a global concern. And it would be very surprising if it did not have an effect. But I have to say that I'm not familiar with specific research on that. I would not be surprised if some has been done. It is a great question, and something that I think certainly we all need to pay attention to.
Okay, then. Well, I would very much like to thank Karen and Richard. It has been an honor to be with them here today. As you can see, they're amazing professionals and they shall do amazing work to help draw the Americas together. I would also like to thank everybody who joined us today and everybody who joins us later on, because they were not able to connect right now. But remember, this webinar has been recorded and it shall be uploaded on the EASP website as soon as possible. Once again, I do want to apologize, especially to our Spanish and our Portuguese speaking colleagues, for the lack of simultaneous translation during today's webinar. It was not possible because we would have had to translate in many, many languages, no, because this is a worldwide webinar. But part of sustaining the community in the Americas and the proposal of that is that everybody feels welcome and comfortable. So it is one of our primary goals as regional team leaders to see how we can make sure that we always have the possibility of English, Spanish, and Portuguese. I would like to remind everybody that the next webinar in this series is scheduled for Thursday, the 18th of June, and it will be hosted by the African regional team. This is part of the series of webinars, and it's an amazing way to connect to new ideas on how to promote and advance suicide prevention. So please keep an eye out for the details. Sometimes we think, well, what do I have in common with Africa? And one might be surprised, you know? I think if we start to listen to all the different cultures, we might learn some really amazing things for our own region. If audience members are interested in hearing more about the work of the ASP and Partnerships for Life, please subscribe to the newsletter. It truly is a wonderful source of information and inspiration. So I really do invite people to explore the webpage and to become more familiar. There is a wealth of information and of resources that are right there at the click of a button. So please go into the webpage and explore it a little bit. If you would like to become a member of YASP, which would be incredible because we can do these things because people become members, you know, the possibility of doing more webinars, the possibility of doing more conferences, of sharing more information. As Karen said, you know, the work has been done. We just need to learn and we need the platform to share it. So if you would like to become a member and help in sharing with all of this amazing work that the world is doing, please go into the website at ias.information. Y quisiera invitar, perdón que es en español y no es en portugués, a todas las personas que quisieran venir a presentar y participar en la conferencia panamericana en Costa Rica en noviembre. Yo estuve hace 2 años en Minneapolis y fue una experiencia inolvidable. Conocí personas con la misma pasión, con los mismos retos, con las mismas iniciativas y realmente hace a uno sentir que es parte de algo y que no está trabajando solitariamente. Esta conferencia va a tener transcripción en el momento en los 3 idiomas, pues nadie se va a sentir que no puede participar o entender. I just invited everybody in Spanish. Unfortunately, I don't have my Portuguese to please come to the conference in Costa Rica in November. I participated in the one 2 years ago in Minneapolis. It was an incredible, life-changing experience. I met some amazing people. I really did. And so I invite everybody, please, hopefully you can come either to present what you're working on or to participate and to listen to the work that is being done. There will be simultaneous translation during the whole conference, Spanish, English, and Portuguese, so nobody will feel left out or that they weren't able to understand. So once again, I thank everybody for your participation in today's webinar. Be well and take care. Bye-bye.